So it's what? Wednesday, April 15th, and we're ready to get started. And I can't find my deck. Where is it? Okay. Today we're going to talk about ACE inhibitors. I've been promising to do some of the science back up on that. That's going to be our major presentation for today. ACE receptor medications like ACE inhibitors and ARBs and the blood pressure medicines. And again, as you know, some people came out very early in a Lancet article saying, we think ACE inhibitors may actually make things worse for people. That has not turned out to be the case. In fact, the pendulum has swung the other way. And we'll go into a little bit more of the update on the science on that. It's not the JAMA article. It was actually the American Heart Association, the Journal of the American Heart Association article. We'll cover that today. We'll get into some detail for those that want to do that. Upcoming topics, COVID-19, are we hitting the peak? And one of the questions I have is, which peak? Which peak for which area? And we'll get into details on that. What do we mean? What do we do if and when we do? Just to let you know, we went ahead and solidified a contract with a large employer. It's a group in Europe, about 250,000 employees, and we'll be providing telemedicine as well as consultation. We'll talk a little bit more about telemedicine today because Janice and Michelle were bringing that up in our meeting, and we're getting more traction. We're getting more people that are interested in getting access to COVID care as well as non-COVID related care, but care like blood pressure medicines. Again, we'll talk about that a little bit later. Previous topics we've covered: distancing, herd immunity yesterday, COVID-19 and heart damage, I think either Monday or past Friday. And again, we've talked about telemedicine in the age of COVID-19. We're going to recover some of that and get a little bit more in terms of detail on what's available and how to access it today. We do have a new service, for example, where you can get more immediate type care, urgent care, same day care. We'll go into all of those right after Carl gives us our little intro. Well, Janice, I see you over there messing with your technology.
I'm looking up more articles for you. Actually, I was just noticing that our state is telling providers how to become telemedicine doctors. Our governor is.
Isn't that funny?
So I thought that was interesting. I was just sending you that article. So they're actually telling you the how-tos, which I find interesting. We were going to talk about telemedicine a little bit, right?
Yeah, you know, pardon the biblical quote, but I've felt like a voice crying in the wilderness for the past 10 years in terms of telemedicine. If there's any generation that needs better access to healthcare, it's the baby boomers. All of us hitting our 40s, 50s, 60s, and 70s with, you know, our body starts to age. We start getting prediabetes. Our doctors don't know how to diagnose it. That prediabetes starts the high blood pressure, the kidney disease, the erectile dysfunction, and it starts killing us. Number one cause of death, heart attacks, and number one cause of disability, strokes. And yet, we're the generation that can't wrap our head around how to access a doc remotely.
Well, I think everybody's learning how to Zoom their families. So remote access is becoming something current, and hopefully will morph into the telemedicine, people being less anxious about using telemedicine.
Right. So before we do, speaking of different people jumping into the act, let me go back. Carl was going to show this, but I'll show this on my side because he couldn't get the tech to work. I'm going to have to start teaching Carl how to use tech. That's a joke, obviously. Carl's major tech guy. Let me see if I can make this, expand this. Oh gosh, now I'm having a, that's what I get for bragging about technology. Okay, okay, so here we go. We're going to do this again. I don't know if they can hear that, but I think they can still hear you and me the way we're transmitting. So this is Yale Medicine. You know, people talk about telemedicine. Well, it's not good quality care. I mean, how many times have you and I heard that? That's so silly. I had a quote from one of our viewers say, "Doc, I'd really love to see you. And my cardiologist doesn't believe in prediabetes, but I live in Connecticut." And that was it. And it's like, really? Yale is in Connecticut, and they're saying, look, we've discovered telemedicine. Here's how you can get COVID care. Here's how you can get access to better care.
And a lot of the major hospitals had a very small component of it, but they are advertising it now.
Yeah. Everybody's jumping on the bandwagon, and you know, I don't think that's bad. It sounds like I've got a little sour grapes. I don't have sour grapes. I'm frustrated that it has taken this to get this generation into understanding telemedicine. Now, do you want to tell them a little bit about what we've already done in terms of telemedicine?
Okay. Well, let me just start out by, for 4 years, we've had a preventive medicine, telemedicine company with a focus on preventing heart attack, stroke, diabetes, and cognitive decline. So it was a specialized type of care. What we have done now in the age of COVID-19 is that we have opened up a non-emergency telemedicine avenue to this company, very much like, you know, a company that Ford worked for a couple of years ago called MDLIVE. So dealing with sore throats, needs for, you know, maybe blood pressure medicine. But and that is beginning, you know, we're beginning to get people that are entering that program, the non-emergency medical care. But we've had several of our existing patients in the preventive program call us who live, you know, all over this country and worldwide, internationally. And a few of them have had respiratory symptoms, which of course the alarm bell went off for COVID-19. And at first, you know, they would share their symptoms with us. And then as the symptoms persisted, or they shared the medical history regarding their symptoms. Then as the symptoms persisted, a couple of them have gone to urgent care. And as you well know, even if you get tested for COVID-19, there is a waiting period. Now, I'm not saying it's the same across the country, but in epicenters, it can be 10 days. And so we had someone call us with what lab results they did have outside of the COVID-19 testing, which was going to be a good wait. And they wanted our, really our feedback, our medical knowledge based on the labs that they got at the urgent treatment center. And, you know, we were able to talk to them about their labs, their symptoms, and when it was an emergency. And that is basically CDC guidelines. When you go for this virus can, you know, overnight or even in hours, change from respiratory to respiratory distress. Respiratory. So we want people to be knowledgeable about that. But there's a real place for telemedicine in our own company as well, where we can provide some guidance.
Yeah, I mean, I think, again, it would be helpful to provide a little detail on like what some of our patients have already been calling in and requesting. So, for example, we've had folks call in and say, you know what, I need to change my blood pressure medicine, or I need just a refill on my blood pressure medicine. I'm not able to access my doc. He's not understanding telemedicine that well yet. He still wants me to come in. We've got that going on. Then we've got, as you mentioned, we've got some of our previous patients that have been with us for a while. Some of them are older, and you know, getting into significant questions about, do I have COVID? Elderly folks who have been out in an epicenter type area and saying, you know what, I just developed a sore throat.
Mm-hmm.
Oh, what do I do? And well, then the next question is, well, have you thought about getting testing? Well, I just went to the urgent care. They did do a test on me, but they really didn't answer any of my questions.
Yeah.
And like you said, there's clear questions and clear guidance that we can provide. Like, okay, number one, are you having a cough, fever, conjunctivitis, sore throat? Are you having those things? Anosmia, can't, don't smell so. And okay, so those might be symptoms of this. Have you been exposed to it? Okay, so those might be, again, increased risk for that. We already know, because they're ones that we've seen so far, because they're our patients, about prediabetes, diabetes situation. So we know about some risk factors. We know what medications they're on. Then the next question is, okay, here's the real issue, and that's where you referred to the CDC guidance. Okay, this can turn into just a sore throat, from just a sore throat to to intensive care kind of stuff,
mm-hmm.
in like very quickly, within a matter of hours. And that's what really the patients need to know. If you don't have trouble breathing, if you just got the symptoms we talked about, the fever, the sore throat, and you're not having problems breathing, you need to stay at home.
Mm-hmm.
At that point, getting a test may or may not help.
Or even quarantine yourself from your other family member.
And you need to quarantine yourself. Clearly increase the quarantine on that. But here's what you also really need to know. Are you having problems? Are your lips turning blue? Or is your face turning blue? Are you starting to lose consciousness? Is your chest getting to where I'm really struggling to breathe? Is it hard to walk from one end of the house to the other? Once you start getting into some of those symptoms, testing is off the table, and calling your healthcare providers off the table. You need to get in for emergency care. And so people need to know when and what they need, whether they need a test, whether they need to be at home on isolation, or whether they need to be in the emergency room seeking intensive care.
Right.
And that's the kind of stuff that we've provided already. And
our patients have told us, I have difficulty accessing my primary care provider regarding this. They just say, go to the urgent care center. Do I want to expose myself at the urgent care center without having some understanding of COVID-19? And I think that's a key ingredient. And there's so much stress around having some symptoms related to this as well. There's so much, especially if you live in, an epicenter. I mean, we're all at various stages. Yeah, we're all at various stages of epicenters. And so that is where I think that telemedicine is so important.
To your point, it's very similar to the situation with good preventive care, for sure, and even just good primary care. Folks don't have great access to that, and that's a need we're trying to fill. As I mentioned before, we just got a huge, a very large contract with a large employer. I don't mean to create too much of that. What's it called? FOMO, fear of missing out. But if you are interested in taking up using some of our services, you need to be thinking about it. It's a difficult time. As you mentioned, it's unprecedented. We haven't had this happen in any of our lifetimes. And so that creates fear. Mm-hmm. It's a 100-year pandemic. And a huge portion of what we've done is that I've given them the counseling in terms of, this is what you need to know about testing. This is what you need to know about accessing intensive care or emergent care. And this is what you need to do in the meantime. Mm-hmm. And you've been providing at least as big, if not a bigger service in terms of helping them calm down, breathe, chill out, and understand what to do next. You know,
Right.
getting that emotion out of the equation. It's a big, big deal. Obviously, we're qualified to do this. I started in emergency medicine, so that and the primary care and the prevention that I've done this is what I do for a living. You want to talk for a minute about how it works, or you want me to?
Well, I can talk about it. We already had a link established, which you'll probably see in a bit, for the non-emergency medical care.
Yeah, it's running on the banner on the bottom.
Okay. Again, those were things like sore throat, cold, UTIs, that kind of thing. We want to provide more urgent same-day care for these questions about COVID-19. So we do have slots available for 15 to 30 minutes. The same-day urgent care would be scheduled with Michelle. Her number is provided.
And one of the things I'll add, and I didn't get time to put that in the slide because literally we decided to do this part about half an hour ago. Mm-hmm. The way most of these will work is that we'll work with Lori, our nurse. She will get the history from you. She'll get the information regarding what medications you might be on, what sort of symptoms you may be having, what sort of questions you have. And then I will join for the meeting, and we'll get care for you. We'll get you what you need. We've always used an electronic medical record. I've got a whole video on that if you're interested in it. Actually, electronic medical records were something I've set up in, gosh, close to 1,000 different programs, even before telemedicine, because e-prescribing greatly improves the quality of care. You know why?
Also speed.
Yep. You know why? Why it improves quality of care? Guess you know the number one cause of medication errors.
Oh.
Physician handwriting.
Oh.
And e-prescribing takes all of that off the table. Mm-hmm. So that's something that your doc should have been doing a decade ago, and you can ask for yourself whether or not he or she actually was. So that's, again, some more details around the system. Now, anything else on our telemedicine offerings, how to access it, any of that before I get into the update, the article on ACE receptors?
Well, I was just going to say, in our own practice, we do both video and calls.
Correct.
So some people may think to themselves, I don't have access to a video, on my computer screen. You don't have to.
Yeah, about 30% of our patients don't actually do video with me. If they can't get it set up, they prefer not to. For most of them, it's not that they prefer not to. For most of them, it's they have an old computer or they have some sort of security setup on their computer, which is not allowing them to access the video.
Right. And some people choose not to.
Yeah, some of them choose not to. Some of them end up seeing me, but I can't see them. Okay. Which is not fair. But
so I just wanted to say it can be very simple.
Yes.
With a phone.
Yeah. Well, you know what? The thing is, this whole thing about telemedicine and reticence of confusion about it is really stupid. Because when Alexander Graham Bell invented the telephone, how long do you think it took for doctors and patients to start talking to each other? This has been going on forever. Mm-hmm. We just can't wrap our head around it, which is silly.
Okay.
Anything else?
Moving into the future.
Finally.
In the current day.
Yeah.
Okay. Thank you.
Thank you so much. Okay, so I'm going to talk about the ACE receptor blood pressure medicines. Because it's one of the better blood pressure medications. These two classes, ARBs, ACE inhibitors, and ARBs. Because they are some of the better ones for decreasing the inflammation, the cardiovascular inflammation that's associated with heart attack and stroke and plaque. We use them a lot. So therefore, we've really kept up with this issue. And I will let you know, I've done maybe 2 features on the ACE receptor medication classes and COVID. And I've done, gosh, half a dozen just brief updates, non-primary topic updates. So this is going to be a primary topic coverage. It's an article that was in the Journal of the American Heart Association. Again, as I mentioned, we put American Journal of the American Medical Association. There was one article on this in there, and we'll probably cover that at some point. So again, if you see that on the title, and Carl, if you could just correct that on the title for reviews. So among the COVID-19 patients, 5 to 30% of them have had hypertension, and 2.5 to 5% have had coronary heart disease. So that's some of the basic components, the basic concepts in the Journal of the American Heart Association article. And you see here, this is a copy of the clip, the front page of the article. It was, oh gosh, what was it, last week? Yeah, April 1st, April Fool's Day. And here's the link if you'd like to, in fact, I'll link on that for you real quick. There's the article. Now, to get back to the slides and the details on the article, again, this won't take very long. You've already heard it, again, multiple times from me. ACEs and ARBs, there's probably a double-edged sword here. The first one is that it might increase SARS-CoV infection, SARS-CoV-2 infection rates. That was the perception that came out. That was a lot of the early scare associated with this. The ACE2 receptor is used by SARS-CoV for entry into the cell. That was where the concern was originally developed. ACE inhibitors and ARBs, ACE meaning angiotensin converting enzyme. We'll mention that again later, but obviously these acronyms, this scientific terminology is not something you need to worry about. For those of you who are geeky and want to know, ARBs means angiotensin receptor blockers. So both of these medications, as you can see from their names, are very much medications that either inhibit that ACE receptor or block that ACE receptor. That's what ACE inhibitor means, and that's what ACE angiotensin receptor blocker. So they upregulate these, the expression of these receptors. Now, what does upregulate mean? And did we make a little bit of a jump? Yes, we did. And again, it's all about that first mechanism, that first fear that comes up. You remember that ACE2 receptor? That is the that receptor is what's impacted by the ACE inhibitors and the ARBs, those blood pressure medicines we've talked about. So they both inhibit or even block that ACE receptor. Now, what does upregulate mean? Well, when you block something like an enzyme or a receptor in the body notices that, and the homeostasis part of the body says, you know what? Something's blocking these ACE receptors. So pardon the nonverbals, but I have to go over and make more of these ACE receptors in order for them to manage their function. And we'll talk about what their function is in just a minute. It's an inflammatory blood pressure increasing function. So if you've got upregulation as a result of ACE inhibitors and ARBs, that is the concern that the first article in the Lancet came out about, the first investigators. They said, you know, that means you've got other places for SARS-CoV-2 to latch on to the cell membrane and then get itself transferred into the cell membrane. Remember what it does is like any other virus. It hijacks the genetic mechanisms of the cell. So that was mechanism one. And that, again, is the concern about potential increase in infection. But if you stop and think about that, if that's a real issue, then why aren't we seeing a lot of people, a huge increase in people on this specific blood pressure medicine getting infected? That's been a major question. Obviously, they're continuing to look for it. And you would think if that were a real issue, that would have been demonstrated by this point. We clearly see increases in obesity. And we're going to cover an article on that over the next week or two. You clearly see increases in high blood pressure. You clearly see increases in age. Pardon me, but I'm not seeing anything in the science yet that says if they are on these specific classes of blood pressure medicines, we see increased risk for this disease. It's just not coming out yet. And in fact, don't rely on me. I'm not the only person looking at this. Tons of people around the world are looking at that question. So let's put that an initial concern, that initial potential impact aside for a minute. And let's look at the second issue, which most people are talking about more as they get into these into this investigation, as they get into these articles, and they start looking at what's happening in the world. It goes back to the same issue, the same reason that many of us have pushed ACE inhibitors and ARBs in the past. They're very good drugs. What they do is they reduce lung damage, they reduce heart damage, they reduce kidney damage. The renin-angiotensin system, this is the system that we're talking about. It causes widespread endothelial dysfunction, increased blood pressure, and varying degrees of organ damage, heart, kidney, and lung damage specifically. ACE inhibitors and ARBs block the renin-angiotensin system. So they might relieve lung injury and decrease heart and renal damage caused by the RAS system. Now, we'll have a pop test on this a little bit later. Again, some technical components of this, but we won't get too deep into it. The key point is that renin and angiotensin, renin is an enzyme that changes angiotensinogen into angiotensin. Bottom line is, this system increases blood pressure, increases inflammation, and thereby increases damage to the endothelium of the artery, damage to the heart, damage to the lungs, damage to the kidneys. The ACE inhibitors and the ARBs block that damage and decrease the blood pressure. So that's why they've been such a popular blood pressure medication. I'm not going to go into further detail on that chart at this point. So the bottom line is this: should patients and doctors discontinue ACE inhibitors and ARBs? And the answer is, at this point, a clear and emphatic no. So here's some of the quotes that you see as you go through the articles. It would be unwise to discontinue these medications assertively because of the protective role of ACE2 in the respiratory system. The inhibitors is supported by ample evidence, whereas the increased danger of infection is still nothing but a hypothesis. On the other hand, there is no immediate need to initiate ACE inhibitors and ARBs because there's been no definitive evidence that they benefit these patients in terms of their immediate survival. So let's not overreact. Let's don't take everybody off of ACE inhibitors. Let's don't start putting everybody on ACE inhibitors. Neither of these things have been proven yet. Let's just calm down and watch what we see. And by this point, we've had plenty of time and evidence to see if either one of these mechanisms were going to be huge actors in this play. More evidence from laboratory and clinical research is needed, as they always say, for further progress in the treatment of COVID-19. So, as I've said before, I've done probably clearly enough videos on this to sometimes bore me to tears. and I'm sure they bored some of you to tears as well. But again, it's what we do. It's the information we're trying to make available to folks. And having said that, I will break off and see if we have any comments. It didn't look like we had any, but I was looking at the wrong place, the private chat. So just call me Viv. Good morning from Phoenix. Good morning to you, Viv. Dave Murphy, good morning. Mike Riffin, kidney and liver destroyers pay real well. I think it's Gabriel from Kiev in the Ukraine. Please cover the blood clotting issues in a future episode. I haven't heard of those yet. If you could send me something, I would appreciate it. There's clearly blood clotting problems once you start getting into intensive care and very serious COVID-related disease. If that's what you're referring to, again, please let me know. If there's a specific issue around it, let me know. And let me just, rather than leave that alone, let me just say this. There's a thing called DIC, disseminated intravascular coagulation. That happens with a lot of very intensive diseases, ICU-related diseases. You start having things that, like inflammatory processes, and so much tissue damage. And what does tissue damage cause besides inflammation? Clots. Inflammation causes clots. So you start getting a whole lot of tissue damage from anything, and you start risking DIC, disseminated intravascular coagulation. That's one of the things that the intensivists, the hospitalists deal with all day, every day. But if you're talking about something different from that, Gabriel, please let us know. David Ivers, good morning to the both of you. You know, somebody, I think it might have been Heidenick yesterday, said, good morning to your daughter. I thought he was talking about our daughter in Santiago, Chile. He was talking about my wife. Everybody loves to give me a hard time, and I do appreciate it. Just call me Viv. Good morning from Phoenix. Joe Campbell, please help me find information on a regular heartbeat, not a fib. There's a whole bunch of causes of irregular heartbeat. AFib is clearly the most common, but I think I need to know a little bit more about what you're talking about. First of all, if you're saying, I'm having irregular heartbeats and it's not atrial fib, my first question for you would be, how do you know that? Because the majority of people that come to me and say, yes, I do have this fluttering in my chest every now and then, and I don't have atrial fib, actually have atrial fib. It's very similar to the issue of insulin resistance. And a lot of this they've learned, unfortunately, bad habits and bad information from their own doctor. They've got insulin resistance, they've got undiagnosed prediabetes, and they're saying, I've got problems, I've got plaque, but I don't have that. How do I know that? Because my doc has done a hemoglobin A1C, and it's not 6 yet. So he tells me I don't have prediabetes. Wrong. Same thing with atrial fib. The vast majority of atrial fibrillation is not diagnosed, and it's because most docs, a lot of docs don't know how to diagnose atrial fib. It's called paroxysmal. The vast majority of atrial fib is also similar to the majority of prediabetes. It comes and goes. It's not there all the time, and it's called paroxysmal atrial fibrillation. In fact, what we have found is that we used to think that the majority of strokes were what we called, another senior moment. I can't remember the actual name, not cryptic, but unknown origin, strokes of unknown origin. As they started to investigate further, what they started to find was the vast majority of these strokes were actually being caused by atrial fib, which had not been diagnosed yet, because again, the patient was not having it most of the time, or at least when the patient was having it, they weren't aware of it. So, a little bit deeper discussion I think we need to have regarding your question, Joe. Teb Tingry, as a vet abroad, the VA actually had decent psych telemedicine since about 2013. Yep, maybe it was 2014, but it was not bad at all. You know, I'm working, I started doing a little bit of work with a friend of mine, Fennell Hicks. Fennell's done a lot of work with the VA, and he put in a couple of comments about VA and how this is going to improve telemedicine care for the VA. Thanks for the comment, Teb. Oh, and good morning to you as well. Here we go. Dave Murphy. Thanks again to you, Janice, and the rest of the team. Stay healthy and stay safe. And thank you, Dave. Again, we support these activities off of my day jobs, and in the past, it was almost all supported by day jobs. I retired again a year and a half, 2 years ago, and it's been focused supporting it out of our retirement. The fact that folks like you, Dave, make a contribution from your own money really means a lot. Again, most of the death and disability that's going on out there is totally unnecessary. But it's happening because patients don't know enough, and frankly, doctors don't know enough. Doctors don't know very well how to diagnose, how to look for prediabetes. They don't know very well how to diagnose and look for paroxysmal atrial fibrillation. And those things are killing us. They're causing strokes, they're causing heart attacks, and sometimes you feel like the Maytag repairman. Nobody's interested. But unlike the Maytag repairman, it's not because nothing's going on. It's because the expectation is that you're going to have a heart attack or a stroke and die or be disabled in your 60s or 70s. And that's not the correct expectation. We should have an expectation that we live healthy lives into our 90s and beyond. But I'll be happy to get us started into our 90s. So, Greg Clopton, there's an article in the Washington Post this morning discussing organ damage in C19 patients. What do we know about long-term damage in those who have recovered? Well, this may sound a little bit sarcastic, Greg, but how long have we known about COVID-19, SARS-CoV-2? Just a few months. So there is no experience in terms of long-term damage. That's one of the big questions, though. It's a great question for all of us to be thinking about. Now, when you look at some of the logic and precedent around it, this is not the first short-term viral or other illness that's caused a lot of intensive care. It's not the first short-term trauma. You know, lots of things put people in the ICU, ranging from heart attack to stroke to car wrecks, you name it. And those same people get heart damage, they get organ damage, kidney damage, lung damage. And as we've covered in the heart damage thing, what was a couple of days ago, we know they're getting heart damage because the heart has to pump, and even harder during all of this disseminated intravascular coagulation, this rampant inflammation. And we also know they may not have enough, they may have plaque in those arteries in the heart. So they've got decreased oxygen, yet increased need for oxygen. That damages the heart. We also don't know, for example, whether or not COVID is doing direct viral damage to the heart. But again, we already know that a lot of these problems that we're seeing are not new. Now, for the most part, this damage that happens immediately in ICU tends to be relatively short term. It's not creating huge amounts of long-term disability. That is part of the maybe silver lining on some of this picture. But again, that's just a doc who's taking care of a lot of patients talking about what I've seen in the past. We do not have history on COVID-19 yet, long-term history, to know the answer to that question. Uninsurable. Please focus the slides. They're blurry. Thanks. I'm wondering if that happened today. We've had that problem in the past, but usually you can tell today, the day of, and that wasn't it. Okay, so this is Gabriel in Kiev again. DIC, yes, I was referring to that. There's a recommendation to use heparin. When the DIC is over 5, the patient is not likely to survive. Yes, once you get to certain levels of DIC, the patient's in extremis. Now, and do you use, yes, of course, that's one of the standard treatments for DIC, disseminated intravascular coagulation. Now, one of the questions is DIC killing the patient? And that raises some of this thing that you've started to see popping up all over the place. It's the patients that go on ventilators that tend to die. So therefore, maybe the ventilator's killing the patient. You know, maybe the DIC is killing the patient, maybe the ventilator is killing the patient, but let's stop and step back for a minute and recognize, when do you get DIC? When you're already in extremis. When do you get a DIC that's very high level? When you're further in extremis. And by in extremis, I mean about to die. Very at high risk for death at that point. And guess what? They don't put people on ventilators unless people have very serious respiratory problems. They're having trouble breathing. Well, you don't get to that level unless you've got very high risk of death. So it's a good question. 147 degrees west. I sent you a reply in another article on your question about taking over leukocytes and T cells. One of the questions that 147 sent us was, we know each other, we've talked. She's in Alaska. And the question was, is COVID-19, SARS-CoV-2, is it actually hijacking cell lines within our immune system? And the answer is, it does appear to be the case. We will find out more as the science progresses. And here's the thing that was raised, and people, you know, that really starts jacking up emotions, and that is one of the other viruses that we know that does that is obviously HIV. I don't think there's any other significant comparison with HIV right now. And again, that's why I'm a little bit worried about linking that. This is not the only infectious agent. This is not the only injury, metabolic injury that damages and maybe even hijacks the immune system. So good morning, just having coffee. Doc, the blood clotting issue gets into the leukocyte issue I've sent you. That's exactly what we're talking about. The DIC rises just before death. The autopsy study from NOLA shows it is significant. Well, there is no question in my mind that either of those issues are significant. I would agree with you 100%. Exactly, 147. Yes, and I would agree. Supplements, COVID-19, vitamin C, vitamin D, astragalus, I think, astragalus, mushroom formula. We've had, if you go back and look at our supplements, we've covered supplements several times. I went back to starting adding about a gram and a half of vitamin C per day, personally, after doing my videos on vitamin C. Always have supplemented with vitamin D. Usually, I've done a lot of work on vitamin D. You can look at other videos that I've done. Not a significant amount of evidence specific to SARS-CoV-2 for either of those, just like, you know, it's too new. But both of them make a lot of sense. For the past 2 to 3 years, I've been recommending for all of my patients to go ahead and take a 5,000 international units of vitamin D3. Vitamin D has, in several different meta-analyses, has been shown to shown signals of helping specifically with things like prediabetes. And if there's anything that's killing people from heart attack, disabling them from stroke, and killing them from COVID-19, it's prediabetes. So now, vitamin D is one of the few supplements that can cause damage. It can actually kill you. I know a doc who knows of a patient that had significant disease. I don't know if it killed her or not, but it can shut down your kidneys. So don't just take a whole lot of vitamin D3. You can take 5,000 international units a day. No, there's plenty of science behind that. Nobody has ever gotten hypervitaminosis D from 5,000 units a day. What you do need to do is don't guess, test. You know, it's just like COVID-19 and so many other things. Quit guessing and just test. See what level you're at. Now, a lot of the labs still say that 24 to 40 is the proper level for vitamin D3, and it's not. It's more like 60 to 90. Once you start getting over 90, I get nervous. We actually had a patient that came in to see me once. She had been seeing another doc, and the doc was giving her these 50,000 international unit pills. What either the doctor didn't tell the patient effectively or the patient didn't understand was this was to be once a week, not once a day. So she got up to levels like 120, 130. We got her back down, educated her regarding what the problem was, and she was fine. She actually started to see some kidney problems, but again, we got her back down soon enough to where she was fine. And I don't know the name. I've seen the lady a few times. I knew her name. I can't remember it right now, but you can look up increased vitamin D in my videos. Good luck on trying to find it. The algorithm is getting cranky unless it's just getting cranky recently. Uninsurable. Hi, I'm a new subscriber. I'm slowly making changes due to my CAC, coronary artery calcium score of 1460. I didn't think my lifestyle was that bad, but I'm thinking undiagnosed prediabetes. Need more tests. Thank you so much for sharing that. I typically will get, actually, most of my patients either get serious and come see me because of an event or an elevated calcium score. So I'd love to see you. A lot of people do it on their own, just sort of a do-it-yourself medical. Anyhow, I won't go there. But typically we'll get people that, I've got a ton of people with calcium scores over 1,000. They will typically come in and be very scared. And then within 6 to 18 months, they're totally comfortable. They've got it dialed in. They know what increases their problem and what decreases it, and they know that they're stable. So don't give up hope. You can be there exactly where you need to be. 147, also use astragalus with matcha. Pardon me for mispronouncing it. I was mispronouncing, what was I mispronouncing the other day? Oh, ionophore and ionophore. It doesn't have a T in it. There is ionophore, but that's a different word. It's a related word. It has to do with absorbing through the skin. But gosh, I got a lot of grief for my mispronunciation. Thanks for your patience with me as I did. Idiopathic. Yes, I think what you were, idiopathic was one of the terms used for strokes. But there was another term as well. And again, it just meant they did not know the cause. Idiopathic means that as well. Thank you very much, Karen. Bob Weiss. Hi, Dr. Brewer. Bob Weiss, North Georgia Mountains. Beautiful day. How are you, Bob? Dr. McCord, just south of Cincinnati. Interesting to consider how renin-angiotensin-aldosterone system dysregulation may relate to mechanisms such as insulin resistance and adrenal stress. Restoring metabolic balance is always key. So I got Kevin, I hope you don't mind me sharing, but I got a communication from you recently that looks like you're about to get ready to launch. I'm excited to hear that. Joseph Page, are there better and worse types of vitamin C? Oh, yes. There's a whole boatload of debate around that issue. And I have to tell you, the folks that study this tend to focus on lysosomal vitamin C. But I have to tell you, I don't know the science well enough in that space to know whether the lysosomal is actually worth the extra expense. I know that you get a lot of that with CoQ10 and ubiquinol. And the reality is the more expensive ubiquinol is probably not worth the extra expense. Is the lysosomal vitamin C worth the extra expense? I don't know. I don't know. It's a good question. I will tell you this. We will get a few comments as a result of this discussion where you got some very strong, committed people saying, oh, yeah, it's definitely worth it. The other stuff is really bad. And then others who will say, you shouldn't take ascorbic acid at all. It's not vitamin C, and et cetera, et cetera. I tend to believe the latter a little bit more than the lysosomal issue, but again, I'm not the guy to give you good facts on the relative value of lysosomal vitamin C versus regular vitamin C. Do we offer vitamin D test strips? Yes, we do. We do that on all of our new patients, Bob. So give Michelle a call, and we can get you set up for that. Dave Murphy, do you recommend a follow-up CAC, coronary artery calcium score, after an initial high score, 2600? If so, how soon after making changes? Well, see, that's one of the problems with coronary artery calcium score. You don't get a huge amount of change. In fact, if you're going to get a change, the usual type of change that you get is an increase. And here's the other thing. Here's the kicker. Even when you improve your lifestyle dramatically, you will still, over half of my patients will start off with an increase on their calcium score. Now, why is that? Well, you're looking at calcium. You're not looking at soft plaque, which is the real danger. So if you've got a lot of soft plaque, and again, I see that a lot. Somebody come in, they've got a lot of soft plaque, moderate amount of calcium, or what they think is a whole lot of calcium. We'll get them tuned up. They'll lose 30 pounds if they need to. They'll get started on the other lifestyle changes they need to start. They'll get the carbs out of their diet. They'll get on metformin and or pioglitazone. They'll do, all this stuff. And then they'll expect to do a victory lap after a huge decrease in their next calcium score. Instead, what they'll see more often than not is an increase. And I warn them beforehand, that's what you're likely to see. Why is that? Because if you take what was soft plaque in their earlier score and stabilize that, part of that stabilization is calcification. See, soft plaque is a soupy, soft, liquid thing. And when you start to take that liquid out of there, it stabilizes the plaque. But you get deposition of calcium. You get some calcium in there as well. Now, we've actually recorded, and a few people have decreased their calcium score. You may remember a fellow named John Lorscheider who worked with us for about a year and a half. John actually got a significant decrease in his calcium score, like a 50% decrease. But John did some incredible work. He went from Joseph Kraft insulin survey showing a blood sugar over 300 to a space where he was never getting above 110, 120 on his blood sugar. He also lost 40 pounds. And like Gene Lovell, he was somebody that most people would have said, he doesn't have 40 pounds to lose. These guys did incredible work. And Lorscheider, again, documented that he had a huge decrease in his CAC. So what would I recommend? Back to your specific question. I don't often recommend follow-up with these. If you haven't had a CIMT, you really ought to start getting that, because you can start seeing significant year-by-year changes in a CIMT. In fact, if you go back and look at some of my videos, I went from a 73-year-old arterial age to 68, 60, and then back down to 52. I get a lot of these CIMTs, so I was getting a lot at that time period, and clearly got a huge decrease in it. And it was part of it was because I finally broke in and started taking a statin when I needed to. But I cut the carbs. I lost about 10 more pounds. You know, there's several things that I did. Bottom line is CAC is not great for managing that. I would, as you can tell, I've gone a long time about this issue. I'd strongly consider getting a CIMT. At Rob, liposomal vitamin C, 2 grams per day, no problem. See, I told you we'd start getting some comments about that lysosomal. S-Benet, idiopathy is pandemic. Not sure about that. I will say this, there's a lot of stuff in medicine that's idiopathic. James Cantor, do you know his thyroid medication will raise blood sugar levels, especially after taking it in the morning? In some people it does. But low thyroid is a bigger issue in terms of a more common cause of heart attack risk and prediabetes. So thank you guys. It's been a fun morning. I appreciate your interest, and we look forward to talking again. Don't get too wired up. Don't get too frustrated with what's going on out there. Recognize that again, if there are a couple of themes in here, it's, you know, there's always something new in terms of challenges. It's like, was it Rosanna Dana said, it's always something. They're just react. Don't overreact. Don't crump. Don't get too frustrated, depressed, or emotional. We'll get through this. And we're going to get through it a lot better than they did 100 years ago with the Spanish flu. A lot better. The other theme that we tend to see, as I've mentioned before, is that the real pandemic, the thing that's killing and disabling more of us than COVID-19, than SARS-CoV-2, is undiagnosed, unrecognized prediabetes. So thank you again for your interest. Thank you, Carl. Have a good night.
Thanks, Doc, too. Bye-bye.